A very good evening, everyone. In continuation to our efforts in disseminating science of genitourinary cancers, we are here with the third module of ICEGU, covering non-muscle invasive bladder cancer aspect, its approaches, as well as its treatment. Without wasting any time, I would like to invite Dr. A.K. Ved for his opening remarks. Over to you, sir.
Thank you, Ritika, for supporting us through these events and the commitment AstraZeneca has shown towards the educational symposia we've been having online. So as you said, this is the third in the series of the symposia, the online webinars aimed at disseminating information and more education in the space of urogenital cancers. This is a very unique model where senior faculty, they present the background data on certain tumor type or subtype, and where the young budding oncologists, they get an opportunity to present their cases and interact with the senior faculty. I have my thanks to all the faculty, the participants, AstraZeneca, as I said, Ritika, you've been very supportive, and Rajesh and Priyanshi, it's your hard work which has seen 190 registrations for today's event. Now, friends, I don't need to tell you about the non-muscle invasive. We are going to have a presentation on that, but we know that this is there is a heterogeneity and there is a heterogeneous subclassification of this disease entity. And over a period of time, despite all the risk stratifications which have been put forth by the major professional bodies, a subset of patients would progress to muscle invasive, and that's the challenge, to prevent a non-muscle invasive getting into a muscle invasive category. And not only that, within that space, as high as about 40% patients can still recur within the first 2 years, and 10% progress to a muscle invasive entity. Now, a lot of research and a lot of effort at preventing these recurrences, progressions, and we'll sure have more information on that. And I'm sure this is going to enrich our knowledge and help all of us practice a better way. With that prelude, I hand over the proceedings back to Priyanshi to take the proceedings forward. Thank you so much once again.
Thank you, sir. We'll just share the screen for sir. Just give us 1 minute.
Hello.
Yes, sir. Yes, sir. You are live.
Okay.
It's just coming.
No problem.
Yes, sir, I'm sharing it right now.
Thanks.
Is Just let me know when this is visible.
No, I can't see it yet. Yeah, it is visible. So
Okay.
just
Yes.
enlarge it. Thank you so much. And sorry, I could not share it somehow. So that unraveling the landscape of urothelial carcinoma and approaches to treating NMIBC, that is non-muscle invasive bladder cancer. Um, uh, Next slide, please. So this is the agenda to know about urothelial cancer and the spectrum and treatment of NMIBC as we call it. Uh, Outline of the presentation for today up to from anatomy up to management of NMIBC. The next, please. So to begin with, a small about surgical anatomy of the urinary bladder. Basically, it is a hollow, muscular, kind of elastic pear or oval-shaped distensible elastic organ right at the pelvic floor. The only organ in males below that is the prostate. In females, as you know, bladder and urethra directly connected. It is lined by transitional or urothelium, if we call it that way, and it has a layer of lamina propria, which contains a rich plexus of vessels and lymphatics. Bladder emptying involves the parasympathetic nervous system, and it has a central nervous system connection. Stretching the bladder wall triggers the contraction of the detrusor, and the pathway goes up to the CNS and comes down. The next slide. About the epidemiology, based on the Globocan data, bladder cancer accounts for 3% of the global cancer diagnosis. Worldwide, it is 6th commonest in men, 17th commonest in the females, and overall has a 5-year prevalence of 22 per 100,000 persons. So with regards to disability adjusted life years, it ranks 15th. Next, please. If you see the yellow color bar on the graph, that is bladder. So according to Globocan, there were 573,000 new bladder cancer cases and 213,000 deaths in 2020. So although it is 6th and 17th in males and females respectively, it does contribute to a big in numbers. Not only that, it causes probably a lot of financial problems to many patients. The next slide. So the risk factors, males are generally more affected. The age which we generally talk about is elderly. So age more than 65 has been seen in white race, but I guess in our country also we see a good amount of bladder cancer. Tobacco in any form technically can act as a risk factor. uh, Family history, genetics, birth defects, chronic bladder infections, past pelvic radiations, where second malignancies can come. In the genetics, there is Lynch syndrome, in which there can be colonic cancers along with urothelial cancers. In environmental risk, chronic arsenic exposure. As per the occupational risk factors, polycyclic aromatic hydrocarbon and aromatic amines, the phenyls, obesity, diabetes, schistosomia, hematobium infections, and certain drugs like cyclophosphamide NSAIDs. These all can predispose or they are quite high risk factors for bladder cancer. And many patients who get bladder cancer, somewhere or the other, the link comes to all these things. The next slide. So roughly most 90% of the cases are urothelial cancers. The remaining 8-10% can be the other cancers, out of which squamous and adenocarcinoma form a bigger percentage in the remaining 10%. The next slide, please. So other very small, like 3 to 5, 6% will have these common variant histologies which we see. And amongst them, commonly, I have a list of 10 of them, but commonly which goes through our eyes is a micropapillary, nested variant, plasmacytoid, small cell, lymphoepithelioma, sarcomatoid. I mean, these are more commonly seen in the histopathology reports. When I say common, common in the variant histologies. The next slide. TNM classification. So up to T1, we call it non-muscle invasive bladder cancer. T2 is actually the muscle invasive. T3 is when the muscle invasive goes perivesical, microscopically, macroscopically. T4 is when it goes to the adjoining organs or the lateral pelvic wall. The nodal classification has N1, N2, N3, and metastatic is the usual one. Next slide. Going on stage, uh, as mentioned, non-muscle invasive bladder is up stage 1. The stage 2 muscle invasive bladder cancer, locally advanced, is probably what will go to stage 3A, 3B, 4A. And metastatic will be 4A, 4B. Next slide. In the prevalence of non-muscle invasive bladder cancer, about 70 to 80%. It's a major share. Again, out of which 60% are superficial, very superficial. That is TA. TA is just the urothelial, outer urothelium layer. 30% will be T1, which breach the lamina propria. And there are 10% carcinoma in situs. The muscle invasive bladder cancer is like 25%, and the remaining 5% are advanced bladder cancers, which would be metastatic. Next slide. Coming to the non-muscle invasive bladder cancer conundrum, it is a tumor that does not invade the detrusor muscle, but can extend as the stage 1 into the lamina propria. Usually papillary tumors, but they can be either papillary or broad-based. And the broad-based would be the basal marker ones, cellular layers, where they can further go down and they are very aggressive. They may be single or multiple. They may appear pedunculated or broad base, narrow base or broad base. And the mucosa around the tumor is often edematous. It can be angry looking, dilated blood vessels. There can be some satellite tumors around the main tumor. These all can be there in NMIBC. Next slide. We characterize it after in the pathology with respect to the stage, the T stage, the NM in stage 1, when we call NMIBC, we expect N0 and M0. So the T stage matters here, TA or T1. The grade, this is the classification used now. Punlump, low grade, high grade. So papillary urothelial neoplasm of low malignant potential has been coined to actually talk about very low malignant potential lesions. And then we follow by low grade, high grade. There is a practice where some pathologists give equivalent grade 1 to 3 also, which was the older terminology, because there is a slight overlap in both classifications. And then coming to the risk stratification. So low risk, high risk, some give very high risk. Next slide. So the NCCN would give a very high risk criteria. So low risk, intermediate risk, high risk, very high risk. And the next slide, please. And many times in actuals, we use the EAU classification, which is a slightly stronger classification, or if not stronger, it is a more strict classification where there are too many variables. But this works well probably when we try to take decisions about bladder cancer. So I'm not reading the details in that, but we have low, intermediate, high, and very high risk again. And the very high risk are totally different, managed with different decision making. The low risk, intermediate risk, high risk, every of these categories are managed differently. So next slide, please. In the symptomatology, in the early stage, either we may have no symptoms, or the symptoms which are like frequency, urgency, sometimes a minimal burning, irritation, or increased frequency in the night. And some will have hematuria, which is one of the most, it's like the symptom in a bladder cancer. Symptoms of advanced or metastatic may be different as in any other advanced cancer. So there can be urinary retention, there can be obstruction of urinary tracts causing other kind of pain in the abdomen. There can be weight loss, loss of appetite, tiredness, bone pains, and other things. So many of the patients 85% around will present with a gross hematuria, or they would have missed the history of hematuria sometime or the other. Next slide. In the diagnosis, we have medical history. Next slide. We go for laboratory tests, a biopsy, which is done during probably the cystoscopy, and certain things like a cytology, which is from the urine cytology. So a detailed history is important. A physical examination, which will sometimes, if there is a large tumor or if there is a bladder tumor obstructing the whole ureter, causing a back pressure hydronephrosis, there will be an enlarged kidney. Very rarely in advanced disease, somebody might have a para-aortic mass or a pelvic mass. These are there. But many times nowadays, we will have patients coming to the doctors with hematuria, and very extreme presentations are not so common as earlier times. Next slide. So in the lab tests, there will be presence of blood in the urine. We can either find it as a microscopic or a gross hematuria. The presence of tumor cells would be seen in a urine cytology. Earlier, we used to think in hematuria, we will never send cytology. But unless it is absolute gross hematuria, when we don't send cytology, the other times we do send a cytology. It helps us to reach the diagnosis. Again, there are other tests like NMP22, bladder tumor, BTA, and which are not routinely used in diagnosing new bladder cancers, but they are sometimes used today when we want to avoid a cystoscopy and still follow up a patient. Next slide. So main thing which we do later on after the basic blood urine tests and maybe a fitness is either a flexible or a rigid scopy. A sonography is a test which can always be done before an invasive cystoscopy because it is a bedside, easily available test, and it will give us a certain diagnosis of a bladder mass, as well as if there is any upper tract hydronephrosis, hydroureter. That is features of upper tract obstruction due to a bladder tumor down. So basically white light cystoscopy. This is a normal cystoscopy. As I said, the rigid ones are done under anesthesia. Office cystoscopy is with flexible. It will give us the diagnosis. It will give us the characteristics, papillary or on a narrow base or a solid base, or a papillary with a lesion which is not so papillary. It is rounded lesion. And we can further take a biopsy. If we are using a rigid under anesthesia, many times we go ahead and complete the procedure, which is called a transurethral resection of bladder tumor, which gives us a pathological diagnosis. The next slide. There are other forms of cystoscopy, which are sometimes used in case we don't find anything on a white light cystoscopy, which are called enhanced cystoscopy. So the next slide, these are techniques to see or detect the bladder tumors, which would normally be missed by white light cystoscopy. So if you see this picture with the pink on the blue, which is an enhanced image with blue light cystoscopy, and the same image in the white light, you cannot actually gauge that there is a tumor or a vague tumor which is sitting there. Next slide. So there are another procedures like narrowband imaging, in which again we can see vasculature of a particular growth, and we can vouch for those areas that they might be high chance of cancer at that place. And there are other techniques also. Next slide. Confocal laser technique and optical coherence technique, which are also used as methods of enhanced cystoscopy today at some centers. Commonly available is the narrowband imaging in India because it is easily available with the company who supplies one of the video endoscope. Coming to the treatment of non-muscle invasive bladder cancer, as I said earlier, cystoscopy, which is a rigid under anesthesia, we would continue probably in the same procedure unless there is any counseling remaining to be done with a transurethral resection of bladder tumor. And these are the further three things which will come up as the slides go by. Next slide. So in TURBT, basically it is an endoscopic procedure. We use endourology instruments and we would see the inside of the bladder. There is a resectoscope where with the help of monopolar electric current, we would resect the tumor. Now, either we can resect the tumor chip by chip in pieces, or smaller tumors sometimes can be resected en bloc. Now, technically, there is a debate between en bloc as well as piecemeal. There is no great answer to that debate. If there is a good uro-oncopathologist, we get the same answers as far as the pathology is concerned. And as far as there is a doubt that the bladder cancer cells, they can seed on other parts of the bladder, but there is no yet proof that any oblong resection actually matters or a piecemeal resection matters. Next slide. We send the biopsy samples to the pathology lab, and we would expect a good report about the T stage and the grades about this particular tumors. So the goal is to establish good clearance of the tumor, accurate pathological diagnosis, and probably accurate staging, particularly when it is a non-muscle invasive bladder cancer. So next slide. These things we already discussed. In a retrospective evaluation of a large cohort of 2,451 patients treated with BCG, the T1 G3 or high-grade tumors, the second resection improved relapse-free survival. So when we have a high-grade on the pathology when we do the first TURBT, and there are multiple tumors, many times the practice here is to again have a relook or a re-TURBT. So what happens is, the next slide, what happens is, I may have got a diagnosis of a non-muscle invasive bladder cancer, but when I do a re-TURBT, there is a good chance of, again, when I resect the muscle, it coming as a T2 instead of a T1 disease. So this has happened about in 25% of the cases when there was muscle present and negative in the earlier biopsies, and about 55% when there has been no muscle and there has been a T1 diagnosis in the earlier TURBT. Coming to instillation, immediate intravesical instillation, which should be given immediate to 6 hours or at least within 24 hours of a TURBT. This is to prevent tumor cell implantation and a very early recurrence. This has been a systematic review, and meta-analysis of 13 RCTs demonstrated decreased risk of recurrence by 35%. So what happens basically is whatever cells are shed and they would be potentially implanting on the bladder urothelium would be probably killed by this immediate intravesical chemotherapy. Next slide. So the drugs used are mitomycin commonly, epirubicin, and gemcitabine. Many lot of people use mitomycin. Coming to intravesical therapy, which follows. So this itself is a very big topic, but just to give an overview, BCG is one of the best drugs. It has the best data. It's still the gold standard to be used as an intravesical agent post TURBT, and it is not used immediately, but it is used in a structured way after 15 to 20 days after the TURBT. So it kind of acts like a local immunotherapy agent, and probably it is one of the oldest immunotherapy in the treatment of cancer. BCG induces a non-specific pro-inflammatory cytokines released to fight against tumor cells. So it has been compared with chemotherapy, but no significant difference was found. BCG in some reports has been better. And about 5 meta-analyses have confirmed that only TURBT versus BCG after TURBT, BCG is superior. The next slide, please. There are certain protocols which are used with the BCG. So there is a induction and maintenance. So induction is a very standard dose of BCG. Usually we prefer nowadays 80 milligram, which is given once a week for 6 weeks. And the 2 maintenance protocols, out of which the SWOG protocol for 36 months, which is 3, 6, 12, and goes on every 6 monthly till 36 months. And the other protocol, which is a monthly protocol for up to 12 months. So both these protocols have shown good effect and slightly better with the 3-year protocol. The problem is BCG is a very strong, it's a vaccine, basically a very strong one. We are putting bacteria into the bladder. The infection troubles many people. Next slide. And as the infection troubles the patient, not many people complete the whole dose or the schedule. So that is with the maintenance BCG. We have to take a lot of care of the patients who receive maintenance BCG. In intermediate risk, we recommend it for 1 year, and in high risk for 3 years. The next slide. There are other methods of giving. If a certain patient cannot take BCG, then we introduce chemotherapy. So as we mentioned, mitomycin, gemcitabine, or other combinations are also available. But these are assisted techniques for giving these drugs, where hyperthermic intravesical chemotherapy or microwave-induced hyperthermia, conductive chemohyperthermia, or electromotive drug administration. These are methods which can slightly enhance the effect of intravesical chemotherapy and bring the results close to the BCG. Next slide. I mentioned about patients who suffer from BCG intravesical, and these are called basically toxicities. So there can be flu-like symptoms, there can be blood in the urine. Uh, it can just be reflect local urine tract infections, can form granulomatous prostatitis, dysuria, epididymoorchitis, cystitis, BCG sepsis, and a big lot of things. It has been graded into 1, 2, 3, and we have to treat the patient as per the symptoms and as per the grade of these toxicities. The next slide. The treatment ranges from just delaying the dose of BCG and giving increased liquids and paracetamol tablets to going to the spectrum of giving anti-tuberculosis therapy. So the contraindications to BCG would be a visible hematuria, active tuberculosis, patient with severe immunosuppression, allergy to BCG, recent traumatic catheterization, symptomatic UTI. And in these patients, you usually avoid other patients like on those on rheumatoid arthritis or something who are already on steroids. These patients are the ones where we try to avoid BCG. Next slide. Uh, BCG shortage. This has been seen in India also, and much more in the Western countries. And since 3, 4 years back, or maybe 5, 6 years back, this has been the issue in Western countries. And then they were using it only in the high risk patients. Chemotherapy is not the best option, but they have been exploring chemotherapy with mitomycin, gemcitabine, epirubicin also for these purposes, and gem-dosi as a combination. With shortage, originally we used to use 120 milligram, but also because of the side effect plus shortage profile, we use 80 or even 40 milligrams and so on. So next slide, please. So this has been an issue about the shortage, and coming to the treatment of low grade, probably low risk NMIBC. Uh, After the TURBT, if we have that diagnosis and we have given an intravesical chemotherapy, next slide, we just follow up that patient after 3 months with a cystoscopy, and if normal, after 9 more months, that is 1 year, and then annually up to 5 years. Unless the disease comes back, we have to re-risk stratify the patient. Treatment of high risk is slightly intermediate risk we spoke about in between. We after the TURBT, if the diagnosis is confirmed, we give BCG intravesical for an year. In some cases, we can exchange that BCG with the intravesical chemotherapy. In high risk tumors, we can use intravesical BCG as the first line therapy if available. We also do a repeat TURBT as I mentioned. Next slide. Uh, so a repeat TURBT is done. A high risk, if we have tumors there, this is post BCG. Again, if we have tumors, there are certain conditions which we call as BCG failures. Many of these are very extensive topics in the NMIBC, but BCG failures or BCG unresponsiveness, then the next treatment offered to a certain patient like that, even though if he is stage 1, it would be an early cystectomy, that is removal of the bladder. Next slide. So treatment of high-grade TIS. So primary TIS is a high-grade lesion of urothelium. Intravesical BCG is the preferred drug, and meta-analysis of randomized trials show that CIS treated with BCG had higher complete response rate, 68 versus 51%, and a longer DOR compared with intravesical chemotherapy. Next slide. Surveillance. So for CTA high grade, CT1, CTIS, the follow-up protocol for each of the risk stratified categories is different. I just mentioned about the low risk the intermediate risk has a follow-up profile or a schedule which is between the low and high risk. And if we talk about the high risk, it is we follow these patients 3 monthly in the first year, 4 monthly in the second year, and 6 monthly till they complete 5 years if there is no tumor propping up. If any tumor comes in between anything, we have to re-risk stratify and take the decision considering what was the initial risk stratification and what are we landing at in the recurrence. Next slide, please. So I think we have spoken about this management. Next slide. So current treatments are what we discussed: BCG therapy or intravesical chemotherapy, and in some cases early cystectomy, which would be in a very high risk urothelial cancer setting in the stage 1. Next slide. Sometimes what happens is, in spite of having a recurrent high risk NMIBC or at the beginning very high risk NMIBC, a patient may not be fit for the treatment which is advocated first, which is the radical cystectomy, or some patients might just refuse to undergo cystectomy, early cystectomy. In those patients, we have to choose either, if I've given BCG earlier, I would choose an intravesical chemotherapy combination. If that fails, then we would still aim at cystectomy. And coming to the emerging new therapies, which would probably help patients in this particular setting, or sometimes also in the high risk setting. There are a lot of immuno-oncology drugs like durvalumab, atezolizumab, nivolumab, pembro, and sasanilimab. There are targeted therapies like Vicinium and vaccines, Panvac, Instillatrine, CGO0070. So these are the new things on the horizon. Next slide, which would probably have a good effect, and particularly in bladder cancer, as we said that this is a very immune affecting tumor. So durvalumab, atezolizumab are PD-L1 inhibitors, and pembro, nivolumab, and sasanilimab are PD-1 inhibitors. So we use these PD-L1 and PD-1 inhibitors in many other cancers today. And we have now multiple studies which are investigating immunotherapy with or without BCG in high-risk NMIBC. Probably it's hypothesized that as BCG has done well for many patients, maybe we can have either these drugs or a combo with BCGs, maybe reduce side effects, maybe give better outcome. The studies will follow and we'll get more data. Next slide. So in BCG naive NMIBC, combining PDL1 with standard of care, BCG may improve response rate, duration. This is what I was just talking about. So there is a Potomac, Alban, and CREST and Keynote 676. Potomac is with durvalumab plus BCG versus only BCG. And the primary endpoint is disease-free survival. In the Alban, it is BCG plus atezolizumab, CREST, and a Keynote with BCG plus pembrolizumab. So these IO therapies have come into a earlier category here, where probably BCG has ruled the roost for a long time, and probably we would see better results. So next slide. Potomac is a phase 3 trial investigating the efficacy and safety of durvalumab plus BCG in high-risk BCG naive patients, particularly NMIBC. Durvalumab is being evaluated in combination with induction plus maintenance BCG and aims to further determine mechanism of BCG resistance. So the study population has a NMIBC high risk, T1, high grade CIS, multiple recurrent large tumors, no prior systemic therapy, and TURBT within 4 months of randomization, randomized to durvalumab plus BCG, durvalumab plus I plus M plus BCG, I only, and BCG, induction plus maintenance. So there are 3 type of schedules, and we would definitely get data about primary endpoint. Next slide, please, with DFS and a host of secondary endpoints. EpCAM is overexpressed in bladder cancers, and its expression level is associated with the grade of disease. Vicinium is an inhibitor of EpCAM, and it has dual mechanism of action and is being investigated in NMIBC. So it selectively targets EpCAM to destroy cancer cells by immunogenic cell death. And immunogenic cell death activates a T cell mediated immune response. It attacks the tumor cells, and probably it would give an action. So that is how Vicinium would work. The next slide. Other investigational treatments, as mentioned before, Panvac plus BCG versus BCG. In BCG unresponsive, Ensiladrin in BCG unresponsive, and a CG0070 in BCG unresponsive. These are in pipeline, and we have some results with it. Next slide. So oncolytic viruses can specifically target tumor cells with therapeutic genes and immune stimulators. Ensiladrin is a non-replicating adenovirus vector harboring the human interferon alpha 2b gene. The rationale is intravesical recombinant IFN alpha 2b protein is well tolerated and had shown clinical effectiveness for patients with NMIBC after BCG. However, the responses have not been so durable, and the gene delivery offers a novel opportunity for local management of NMIBC by increasing duration of exposure. So it is an adenoviral vector gene system, next slide, which would probably help us with patients in BCG unresponsive tumors. At 3 months in this study, 53 and 73% of patients with CIS or high grade respectively had a complete response, respectively with a duration of response of 10 to 12 months. So currently 10 to 12 months is the duration of response. And if you see the relapse-free survival in the graph, in the CIS cohort in the patients who had CR at 3 months. So up to 40% at 24 months. The most common, there were grade 1 to adverse events, and most common grade 3 adverse event was urgency, which is probably not a very severe symptom. So these drugs probably get tolerate well. Next slide. These later drugs, the immunotherapy and the vicinium and the other vaccine-based treatment, these act on totally new kind of mechanism, new kind of mechanisms, and this would probably give a light into the cohort of patients of BCG unresponsive, or those who are contraindicated for BCG, and those who do not want to go for an early cystectomy. So coming to the end, bladder cancer is the 6th most common cancer worldwide. Cigarette smoking or tobacco probably is the most associated risk factor. Hematuria is the alarming symptom, and currently in NMIBC, gold standard is BCG. There are a lot of drugs which are coming up in this same setting as the BCG or BCG failure setting, where we can probably push the cystectomy or the removal of bladder a little away, and probably help get patients a good quality of life with these new medicines. Thank you so much.
Thank you. Thank you so much, sir, for explaining each and everything so beautifully and slide by slide, starting from the pathophysiology to the treatment options available as well as which are going to get available. So with this, I would like to request audience also to put their questions in the chat box, and we will take it during our discussion. So now I would like to invite Dr. Srivatsa sir, and we would be having two presenters today, Dr. Rahul Pradhan and Dr. Shreya Akhil. Dr. Rahul Pradhan is from Sri Shankara Cancer Hospital and Research Center, and Dr. Shreya Akhil is from RML Hospital, Delhi. So Dr. Srivatsa would be the moderator, and for the panel we have Dr. Ganesh Bakshi, Dr. Keval Patel, and Dr. Hemant Goyal is trying to join. He is having some network issue. And Dr. Kamlesh Patel won't be here with us today, but we can start with the discussion, sir. So, sir, over to you. Maybe Rahul Pradhan can begin with the case presentation.
Can you start the slides, my friend? But again, you should not be reading too much into this data. Numerically, there are
yes,
to be better
you can
in
share
all
your
these
slides.
aspects compared to. Sorry, I don't have it.
Rahul, okay, fine. I'll give you the screen share, but I have already mixed the questions as well.
Yes, sir. Yes, sir.
So 1 second.
By the time the slides are coming up, let me compliment Dr. Ganesh for that very patient, very scholarly, and such a highly educative lecture on this Very heterogeneous subject. Very heterogeneous subject. And you really made it so easy for all of us to understand. Thank you so much once again.
Thank you, sir. I mean, in NMIBC is a very extensive topic. Actually, in Uro-Onco surgeons group, we can discuss it for 2-3 days also.
So Ganesh sir, we have a question popping up that which
Okay.
group of patients should go for intravesical chemotherapy?
So one option in the beginning is for immediate intravesical therapies. We have many times we give it after each TURBT, contraindicated if we overtly see a muscle invasive or a very large tumor, or there is perforation in the bladder during the surgery, or a gross hematuria, which can sometimes very rarely remain after the surgery. So otherwise, immediate intravesical chemotherapy with mitomycin or epirubicin or gemcitabine is used. And the further intravesical chemotherapy, which would be in place of intravesical BCG, it can be used in certain sect of intermediate risk non-muscle invasive bladder cancer setting, and in the high risk NMIBCs, where sometimes we don't want to use a BCG, or sometimes in post BCG failures, where we can use mitomycin or gemcitabine or gemdosi, or we can even use the newer immunotherapies which would probably come into picture.
Sure, sir. Thank you. So
Any
Srivatsa
other
sir,
question?
not as of now, sir.
Okay.
Maybe after the panel discussion, we'll have more questions.
Yeah, I'll be sharing my screen.
Okay.
Is it visible?
Yes, it is. It is,
Yeah,
doctor.
it is. You can go ahead with the first case, Dr. Rahul.
Yeah. So this first case is a 34-year-old lady who comes from Uttar Pradesh. No
Your slides are
comorbidity.
not moving, Dr. Rahul.
Okay. Is it?
Can you make it full screen?
It is full screen.
Yeah, now they are. You can go back.
Is the first slide visible, sir?
No, it has come to the 6th slide now. Just go back to the first
I
slide.
think there is a lag. I'll just turn off my video, sir.
The lag is for us also. We are still seeing the 6th slide with no full screen.
Or we can do one thing, Rahul. You can just stop your screen share, and then I will quickly run the presentation from my end.
Yeah.
Which you can present. Can you stop the screen share, please?
Yeah. Yes. Yeah, I've stopped it, sir.
Yeah. Do you see my screen?
Yes, sir.
Yeah. So this is the first case, Dr. Rahul. Yeah, you can go ahead.
Yeah, this 34-year-old lady comes from Uttar Pradesh. No comorbidities. She presented elsewhere. She was evaluated elsewhere, where she had presented with hematuria in January 2022, and she was treated with antibiotics by a local physician. Again, she had recurrent symptoms few months later in November 2022. She got evaluated with an ultrasound. So the ultrasound showed a 3 into 2.5 centimeter mass in the left lateral wall of the bladder with internal vascularity on color Doppler. There was no hydroureteronephrosis and both kidneys were normal. So the patient underwent a CT scan of the abdomen and pelvis with contrast, which showed a 3 into 2.8 centimeter enhancing polypoidal lesion in the left lateral wall. There was no perivesical fat stranding, no hydroureteronephrosis, and no enlarged pelvic nodes. On urine cytology, it was reported as Paris category 2, which is negative for high-grade urothelial carcinoma. Then she was planned for the procedure, that is cystoscopy plus transurethral resection of the bladder tumor after going through all routine pre-surgical investigations. So she underwent the cystoscopy along with TURBT in March 2022. The entire tumor was resected. Of all visible tumor was resected up to the deep muscle. Perioperative intravesical mitomycin C was administered. The histopathology report came as a low-grade urothelial carcinoma, which invades the lamina propria and does not invade the muscularis propria, and there is no CIS and LVI was absent. So she received intravesical mitomycin C induction weekly once for 6 weeks in April 2022. She was not on any maintenance intravesical chemotherapy, and then she underwent a surveillance cystoscopy in November 2022. There was a recurrence, which 1.5 into 1.2 centimeter tumor at a different site. Again, she underwent TURBT in the same setting. The histopathology, this time T1 high grade, no CIS. So after the second TURBT, patient had intravesical BCG induction weekly once for 6 cycles, followed by she had cystoscopy in April 2023, and again she had another recurrent small papillary tumor at a different site. Again TURBT was done. The histopathology, again T1 high grade urothelial carcinoma, no CIS. Then she was referred to us at this stage for further management.
Yeah, thank you very much, Dr. Rahul. I'll just go back to this case and discuss this case first, and then we'll go to the second case. Is that all right, sir?
Yes.
Hello.
Yes, sir. Yes, sir.
Yeah,
This is
yeah.
supposed to be.
So,
Alright.
sir, good evening, everyone, and thank you very much to Ashok Vaid sir and AstraZeneca for this opportunity. My moderation of the cases have become very easy because Bakshi sir has extremely lucidly explained the whole management of non-MIBC in a very simple manner. This was a relatively bothersome case that we encountered a little later in the management. So I would like to start discussing the case, most of which has already been discussed by Bakshi sir. I'll start with Ganesh Bakshi sir. Sir, how often do you consider asking for a cross-sectional imaging upfront?
So with patients presenting with hematuria and bladder lesions on sonography, I often ask for a CT urography or a CT triphasic abdomen pelvis.
Okay, so do you have any criteria, like say in the guideline? It was
One
initially
itself
said
as
that
a dictum in urology is a hematuria, where you can straightforward offer or order a cross-sectional imaging. But when we have technically a smaller tumor, sometimes the guidelines allow us to wait. But if reaching up to 3 centimeters, we would upfront anyways do a cross-sectional imaging. So that clinical call between hematuria and waiting for 3 centimeters, you will have to take a call. I would always do and be safe on the error side.
Yeah. Dr. Keval Patel sir, how often have you identified a new lesion on the cross-sectional imaging which was not reported on the ultrasound?
Okay, so I'll echo what Dr. Bakshi has to say, that sometimes, most of the times, first investigation of choice for hematuria is CT scan. And very rarely, if the patient is having less than maybe 1 centimeter single lesion, then it is not located near the orifices, there is no hydronephrosis, and grossly looking at normal sonography. So we don't do CT scan in those cases, which are very rare to find, and most of the cases we do CT. When such a tumor, we always do a CT, so it's not an issue.
Yeah. So the next question is also to you. Do you want to get a cytology done only once and then, are you are good to go with it, or would you want to repeat 3 consecutive samples?
So what we do at our institute, Dr. Srivastava, is that when the patient is presenting with gross hematuria, we get a CT scan done. If there is no upper tract lesions or nothing, so usually we one cytology sample is enough. Maybe sometimes we can skip cytology as well because it can produce some false positive results also. So I don't think we take 3 cytology samples. One is enough.
Okay. Ganesh Bakshi sir has already mentioned a lot of things about other urinary markers. Sir, do you use any other markers other than cytology in your routine clinical practice?
So currently, we don't choose to, but if a patient is like not going to come up for cystoscopy and cytology, NMP22 is available, and in certain patients we can order them if they are not coming for the other better things. This is what I follow. I mean, otherwise they have a evidence also to be used, but we don't use it so routinely.
Yeah. So these are the other urinary markers in the surveillance setting, but not all of them are available in India. So I think NMP22 is probably the only replacement that we have, but cytology, urine cytology probably still remains the gold standard investigation. So as Dr. Rahul has already mentioned, this patient underwent a apparent complete resection of the visible tumor and received a prompt intravesical mitomycin. So now Bakshi sir has already in detail mentioned about enhancement of intraoperative diagnostics. So Dr. Keval Patel, so how, I mean, do you routinely use any of these photoscopies like the blue light cystoscopy or the narrowband imaging on a routine basis in your practice?
No, we don't use it in a routine basis. We usually do wide light cystoscopy, and most of the times we have aid of cytology. If the cytology is negative and then cystoscopy is also showing low grade tumor, then we are not worried about the other lesions. But sometimes in very rare cases. But I think routinely we do only white light, not photoscopies.
Bakshi sir, what is your take on this?
We routinely use only white light. However, as I mentioned in my talk also, we have the Olympus system with NBI. So we do use it sometimes.
Have you found a practical advantage of using this NBI? And if so, what would be that index case?
So it has to be technically used in BCG naive probably, and with patients who have carpet-like or multiple tumors in the bladder, where sometimes we are like suspicious about whether that small abnormal looking urothelium is a tumor or not. Sometimes I would see, say for example, endoscope touching a bladder wall will provide a reddish discoloration in the mucosa. If I put NBI there, I won't see a vascularity. Vis-a-vis the same reddish discoloration, I put NBI and see a vascularity, there is a chance of having tumor. So it increases the detection rate. I mean,
So only when you have a small lesion which is indeterminate.
indeterminate. There are
Or
fallacies, as I said, given BCG or sometimes with infection, there can be fallacies.
do you think that in a patient treated with BCG, intravesical BCG, we typically see on surveillance that there are multiple red patches here and there. We are not very sure whether it's a BCG related reaction to the bladder or if it's CIS. And cytology is also not very forthcoming in a intravesically treated patient. So do you think that there could be any added role of these photoscopies in this regard, or?
I don't think there will be an added role probably. If I am severely suspicious of that lesion, I would resect it and keep it separately for the pathologist.
Pathologist, fantastic. Now you have already mentioned about on-block resection, and do you feel that it carries any advantages?
Honestly, currently I don't feel it carries any advantages because I do a good resection and I do have a very good pathologist. So both the things debated about en bloc resection are taken care of. The other thought is that you are not disturbing the tumor so much but we don't have a grading of that disturbance so that it sheds cells or it does not shed cell, oblong resection. Nobody knows that.
Dr. Keval Patel, do you use laser resection? Because that's something also now becoming very popular. A lot of people doing laser TURBTs.
Yeah. So I think thulium has picked up in this regard, but we have a very good bipolar system, and we do that bipolar resection, but we have never used laser for resection of this tumor, and I don't find any additional advantage apart from the routine TURBTs, whether it is this laser or bipolar. So we don't use it routinely, but yeah, people have started using it.
No, one of the common arguments in favor of a laser resection is that the bleeding during resection is much lesser. Do you think that it's a practical
See,
situation, or
to be very much practical, I feel that whenever the lesion is big, even laser is going to cause bleeding, or bipolar or conventional TUR. But suppose the lesion is small, then I think the control of bleeding with monopolar is the same as that of bipolar. Okay, and I have never seen anyone attempting laser for very larger tumor. So it's usually laser is used for en bloc resections, which is usually done for small tumors which are pedunculated and which we need to remove tumor along with the muscles. So in those cases, laser resection is preferred. But I feel in good hands, if you are a good resectionist, even monopolar can do the job for you. So it's not energy which matters. It's, I think, which is the one who is doing it matters.
correct? Bakshi sir, one last question regarding laser for you. Do you think that laser resection in a lateral wall tumor can reduce the incidence of operator jerks?
It may reduce. I mean, I am not denying it, but personally, I don't have any experience.
Yeah, I mean, I just wanted
But
to
I
bring all
guess
these thoughts and
laser will
questions.
also create heat. That is for sure.
Correct. So some amount of coagulative necrosis is expected with laser, and there are some challenges to pathological interpretation,
But it might
especially.
reduce the jerk.
Yeah, it might
Because
reduce
here
the
we
jerk.
have an electrical stimulation and laser might cut with another technology.
Okay. So probably for en bloc resections, and probably useful in patients where we are encountering operator jerks. So other than that, the experts feel that laser resection may not add value to the conventional monopolar or
One
the
more thing I
bipolar.
can say, I don't know whether it is practical to say in an academic forum or not, but it will unnecessarily increase the price
Correct.
or charges. I mean, which commonly we don't need.
So if at all we are using laser, maybe with limited indications and limited case scenarios. So Dr. Keval, what's your protocol for administering mitomycin C post-operatively?
So my protocol at my institute is that if post-operatively there is a good control of bleeding, that means there is no hematuria. Usually, as soon as possible, we give it, and I'm not suspecting any perforation or any untoward event. Then, as soon as possible, but maximum we give it within 4 hours. So, as soon as the patient comes out of the OT, in the recovery room, we do that. We monitor the patient there itself, and then we give. Usually, I give it within 4 hours.
Okay, so the guideline says sooner the better, and the advantages are lost if it is done beyond 24 hours of resection. So do you administer it for 30 minutes, 1 hour? Because there is some debate that in the immediate post-operative period, even 30 minutes is as good as 1 hour. What is your take on it?
So at our institute, we usually do it for 1 hour, and we have not found any disadvantage of giving it for 1 hour. If the surgery is good, there is good hemostasis, and we know that there is no untoward, then I think any amount of time is not important.
Thank you. Bakshi sir, this is for you. So you do a cystoscopy and find out that the tumor is very solid looking, broad-based tumor, and probably, in all possibility going to report it as
So
muscle
overtly,
invasive.
I got what you're asking me. Overtly, if I see a big tumor, probably muscle invasive, I might not give mitomycin.
Okay,
And
so
I think for people who are doing TURBT like you are doing, sometimes, you have that gut feeling. You see that muscle fibers also, that there is tumor. And many times it has come true.
So the important take-home message here is that, if there is a strong feeling that the tumor is muscle invasive, it's okay to avoid doing intravesical mitomycin. It is also okay to avoid doing intravesical mitomycin if there has been an incomplete resection, because it is definitely not going to help in these circumstances. So intravesical mitomycin is useful only if we are looking at a probable non-muscle invasive bladder cancer which has been completely resected. So these guidelines I'll just skip. So this was the histopathology report. Dr. Keval Patel, I want to ask you one question. How common is this situation? Low grade but invading lamina propria.
So I think this is not a very unusual situation. We very commonly see low grade TA in our practice, and most of the times I don't know what is the reason. Maybe some, but I think that's not a very uncommon scenario as far as what
This is T1G1 basically. So in the past, the teaching was that whatever is invasive can't be low grade.
Yeah.
Yeah.
So
So
even pathologists believe that way even today. And the moment, honestly, I get a report which is this lamina propria invasion and low grade, I do review this report with a better or a different pathologist.
okay. So
This
you feel
report is a very rare report, like it will come just rarely. LP invasion with low grade.
low grade. So the antenna should be up. The moment we see invasion into lamina propria, then in all probability it is a high grade tumor which has been misinterpreted or misrepresented by the biopsy specimen. So we should probably review the slides, discuss with the pathologist to ensure the appropriate categorization, because almost all subsequent treatment will be based on this report. So based on that report, this patient was advised intravesical mitomycin. I think she had probably received the standard induction course, and then she has had a high T1 high grade recurrence. So in all probability, it was T1 high grade to begin with, which kind of gotten with a recurrent situation because of mitomycin. Ganesh Bakshi sir, now I wanted to ask you. I mean, you explained in great detail how important is risk stratification in routine practice, and should we be doing it on all our patients, or what is your take on that?
So I think risk stratification we should do on all the patients because our treatment decisions are based on that.
Yes.
We also, in some other calculators, we can also have a good amount of counseling done with respect to progression and recurrence. But basic treatment decisions are on the, I use the EAU risk stratification.
So so the important take home message for youngsters here is that risk stratification is a part and parcel of NMIBC management, without which further treatment decisions, further follow-up decisions cannot be made, and therefore risk stratification is mandatory in all these patients. Keval sir, now this is your question. I wanted to know, so technically in the first instance, it kind of fell into an intermediate risk category because of the size of the tumor. It was 3.2 centimeter tumor. So even accepting the pathology report that was given and categorizing this patient as intermediate risk, would you prefer to choose BCG on these patients or mitomycin? And how do you make the decision case to case?
So unless and until specific contraindications for BCG, we prefer BCG in all cases. So for induction and maintenance, we don't routinely use mitomycin or any form of other form of chemotherapy. So our drug of choice is always BCG.
Ganesh Bakshi sir, would you also want to prefer doing only BCG even if the disease is intermediate risk, or would you want to select your cases?
No, I mean, I select cases and in some people I use BCG also.
Okay. So
It is difficult to go for BCG many times because of the side effect profile. But many times I have seen side effect profile with mitomycin also.
correct. So I think it is reasonably justified to use mitomycin in this case or BCG, but most of us tend to prefer using BCG because the chances of minimizing the disease recurrence is much higher and much better with BCG. So this patient actually received only 6 cycles induction course of mitomycin, sir. Bakshi sir, do you recommend maintenance
Data
mitomycin
is supporting giving maintenance with mitomycin, but we don't know. We should give mitomycin
as a
maintenance.
maintenance?
Yeah.
Okay. So this is the data that you mentioned,
One
which
thing is
also
that
was
it's also not very much adequate induction dose also, whether it has to be 6 doses or it has to be how many doses. We have data for that for mitomycin.
True.
Yeah. So, so this patient then subsequently after the first resection received intravesical BCG therapy. Now it is intermediate risk still.
So we can stop at 1 year.
We can stop at 1 year. Yeah, I think that has been discussed, and this has been very discussed in great detail by sir. Sir, this particular case, she has had 2 high-grade recurrences in short span, not even giving time for commencement of maintenance dose. So what would you want to do, sir, for her? She's
So
34.
I'll discuss with her technically. If I consider the initial also T1 say high grade and recurrence T1 high grade, then we should discuss with her the option of early cystectomy. The recurrence was, I think, very small, 1 centimeter or 1.5
Yeah, both were
centimeter.
around 1.5 centimeters, single recurrences, no CIS, cytology negative at all times.
So I will mention yet early cystectomy because you never know. Sometimes we can miss an CIS or somewhere which may not be seen, or in the blind, maybe in the blind area somewhere, bladder, neck, here, there. Um, Advise early cystectomy. If not willing, then go for intravesical combo therapies or something.
So what is your preferred intravesical combo therapy?
So can go for gemcitabine only, or then gemcitabine docetaxel. But many times I use only gemcitabine also.
Gemcitabine 2 grams as a single installation.
Yes.
And do you recommend a maintenance course in intravesical chemotherapies other than mitomycin?
I do recommend. I mean, these patients are doing well, so many times I give monthly dose, which is same.
Which is the same
We
dose.
cover up to 12 months and then stop.
Okay. Dr.
There
Keval
are
Patel.
not much data available beyond that.
Correct, correct. In fact, for the sequential therapies, there's not much data in the maintenance setting also. But whatever is there, I think it is probably worthwhile to use the treatment, maintenance treatment for at least 1 year and see how well they do. Dr. Keval Patel, have you considered using all these, electromotive drug therapies, hyperthermic treatments? Do you think that they will really make a difference?
So the studies for this all this therapy of administrating chemotherapy are showing some sort of improvement in decreasing in bladder recurrence. So, but I have personally don't have any experience of using any of this. We don't have used it at our institute, but like studies have said that it might improve. So, but I don't have any experience.
Yeah. Last question on this immunotherapy. Do you think that it is going to make a change in the way we manage these recurrent bladder cancers, or it is probably going to be one of those drugs?
I think the future studies like which Dr. Bakshi had shown in his slide may give us a better answer rather than speculations now.
Yeah,
I think it might make a change, and I mean, considering that BCG, if you read the whole mechanism of action of BCG, with a lot of things like interleukins and mobilizing immune cells in the body, altering other cells. So immunotherapy should help.
okay. Thank you, sir. I will now hand over the screen to Dr. Shrey Akhil to present his case, and we have just 4 or 5 questions in this case as well.
Time up.
Could someone please share the screen?
Yeah, I'm doing that. I hope it's visible.
Yeah. So good evening, everyone. So I'll be presenting a relatively straightforward case. So my patient is a 60-year-old male, farmer by occupation. He has no known comorbidities. He came with chief complaints of gross total painless hematuria since 3 months, which was intermittent. Amorphous clots were there. He had no complaints of LUTS, flank pain, no loss of appetite, weight, jaundice, or breathlessness. He had no history of instrumentation or trauma. He's a chronic smoker. And on examination, the examination was grossly normal. His ECOG was 1. Next slide, please. His blood routines were within normal limits. The urine routine microscopy showed RPCs about 100 per high power field. The culture was sterile, and cytology was suspicious for high grade urethral carcinoma. His PSA was normal. We did a ultrasound, and which showed his bilateral upper urinary tracts were normal, and urinary bladder showed a polypoidal lesion of about 4 into 3 centimeters over right posterior wall, and the prostate was normal. And in the CECT whole abdomen, his upper tracts were normal, and in UB there was about 45 into 39 enhancing lesion over the right posterior lateral wall. The perivesical planes were maintained with the adjacent structures. So we did a cystoscopy and TURBT. Intraoperatively, it was a broad-based polypoidal growth over right posterior lateral wall. So we did complete TURBT, and perioperative mitomycin C was given. And histopath was confirmatory of urethral carcinoma, which was T1 high grade, and deep muscle was free.
Hello, I'm sorry. Hello, am
Yes,
I
sir, you
audible?
are.
Yeah,
Yes,
very
yes.
quickly. Ganesh Bakshi sir, how often are we really successful in identifying and incriminating etiology in urothelial cancers? Sir, unmute, sir, unmute.
Sorry, maybe 25, around 25-30% patients will give some history of tobacco.
Yeah. So it's really a challenge to identify patients
Beyond
with,
that, it is very difficult because
yeah,
patients
very
do ask, what happened to me? Why?
correct.
So I don't know.
Yeah. So, but I think every effort should be made to look at all the etiological factors possible, I think, as a part of clinical evaluation. But like sir said, it's probably, maybe 1 in 4 where you will actually find some incriminating cause. Keval Patel, sir, of late we have started seeing large tumors presenting with, incidentally picked up on ultrasound scan. Has it been, I mean, has it also been your experience, no hematuria? How commonly are you seeing it nowadays?
So ours is a tertiary care center. So most of the times we do not see such cases. But I personally feel in my private practice also very less number of patients, especially of bladder. We find too much of incidentally detected renal masses or prostate. But in bladder, any incidentally detected masses finding is very rare, maybe 1 or 2%, not more than that.
Not more than that. Okay. I think now coming to one aspect that I wanted to really discuss. Ganesh Bakshi sir, do you see any role for virate scoring in NMIBC? Where do you think it is probably best useful?
I think it will be useful, but I don't know whether it will totally supplement the CT scan. We are very good at reading CT scans, and as well as if I say something like CT urography, I get the whole picture from up to down. If then I'll have to do a MR for the whole abdomen pelvis, not only MR, multi-parametric MR of the pelvis for bladder for virates. It is very good in T2 weighted images. We can easily see the black line, which is supposed to be the muscle layer, and we can uh, probably see that it is a muscle invasive disease. However, I think there are some things to learn on that. It is still evaluating because I have myself had patients with the black line being touched and the radiologist telling me that it is muscle invasive, and it was, I mean, sometimes not muscle invasive. It happens.
So if I mean, I'm sure we are not doing it routinely. If there is that one case where you want to, very eagerly do wire-rats, who is that?
It's difficult to answer that. I mean, smaller single tumors, it is better. It is very easy for me either with a VIRADS or a CT scan to have a tumor which has gone perivesical in both imagings. So something which is inside NMIBC is fine, but then to differentiate T1 and T2 maybe. That's the only thing.
That's the only
In a
thing.
BCG naive patient, that too.
Okay. Dr. Keval Patel, do you think that we can with evolution of wire-rats can actually do away with our routine surveillance cystoscopy, just do cytology or some advanced urinary marker and wire-rats?
Okay, so regarding the first one, I think virets can be a supplement to our routine biopsy and a histopath report, but still we don't have enough data or expertise to replace routine cystoscopy. Again, with the data or the studies which have been conducted, they are not that much favoring or that sensitivity specificity of virets as compared to the biopsy histopath examination. Identifying a muscle in a biopsy is not higher than that. So I think it in near future it's not going to replace. But okay, cytology we as such routinely do before going for cystoscopy in all cases, even in follow-up.
Bakshi sir, just one question on surveillance cystoscopy here. Do you think doing a rigid cystoscopy is better or a flexible cystoscopy is better as far as the diagnostic yield is concerned? Not the convenience. I'm talking of
I
only the
think
yield.
both can be same, because we do rigid, and we would if we see something, we would go with a resection. So that is the only add-on advantage. If you talk only about diagnostics,
Yes, only
I think
diagnostic.
the optics are very good even in a flexible today.
Okay. So I think the last one or two questions. Ganesh Bakshi sir, how often are you doing re-TURBT? Do you think that there is a real
If I have
justification?
myself done a TURBT
Ah,
and I get a T1 high grade, and if it is a single or just two tumors, I may not do a re-TURBT. However, if there are really multiple tumors, even if I have done, and if the diagnosis also says CIS, in addition to what I've resected, I would do a re-TURBT.
okay. So you would also do a re-TURBT if the first TURBT has been probably done elsewhere and the report is T1 high grade.
That is a likely chance. If elsewhere done, then I'll see where it has been done, how it has been noted in the op notes, and then probably go ahead. If there are multiple tumors, I would surely advise a re-TURBT.
Okay. Dr. Keval Patel, this was what Dr. Shrey presented was a bladder-based tumor. Do you routinely practice prophylactic stenting, which facilitates your resection?
No, we routinely don't do, because most of the times the tumors which are involving the ureteric orifice, they'll cause some kind of hydronephrosis. Most of the time, it's very rare to find big tumors which are obstructing orifice and then causing hydronephrosis. So I personally don't find any advantage of stenting those cases. Even if while resecting the tumor, we are able to we are resecting orifice. That is only going to cause some kind of reflex. But I don't think prophylactic stenting is going to help. So I don't routinely do it. And one
In
more thing,
case you have had to do it, sorry, please go ahead.
that in the sir said, suppose the patient comes with a biopsy report and there is no muscle. Again, that is one of the indication where we can go
Yeah,
for
of course, of course, of course. So if for some reason we have had to stent, do you think there is a case for removal of these stents before we start doing intravesical BCG, or are we good to do BCG with the stents on?
No. I think before starting of this, we remove the BCG, remove the stent before starting BCG.
Ganesh Bakshi sir, your take on this?
I didn't get the last point.
No, in case we have had to stent the patient, do you want to remove it before you start BCG, or you want to? Is it okay for the stent to be on?
I mean, difficult question, but generally we would remove the stent in 3 weeks.
Okay. I think we are running out of time. I've already overshot, so I'll stop my discussion here. I thank my esteemed panelists for their valuable insights, and thanks again to the organizers for this wonderful opportunity. And most importantly, thanks to our fellow junior colleagues, who did the case presentation. Thank you.
Thank you so much, sir. I'll just quickly have 3 or 4 questions from the audience. So the first question is, currently Sunrise 3 trial is going on in NMIBC, in which BCG is being compared with TAR 200 monotherapy versus TAR 200 plus cetrilimab. Any experience so far with this drug?
I have already answered. I think Srivatsa can take that.
Yeah, sir, we are just in the talks to enroll our center as a trial center. We have not yet started it, so maybe we can answer something in the next 6 months. Right now is not possible.
And sir, what's the role of immune checkpoint inhibitors for both the cases?
So they talk about a BCG naive case.
Yeah.
So in my presentation, the last few slides were about BCG naive. The data is coming up gradually.
Yeah.
And the data which is there with, say, pembrolizumab, which has been there, it is in the BCG unresponsive setting.
Yes. And sir, does the treatment with BCG induction plus maintenance vary by the stage? For example, stage TA, T1, or CIS?
So not by the stage, by the risk stratification status.
Okay.
If we have an intermediate risk, we just said that BCG we would give up to an year. If we have a high risk, then we would probably like to give the full protocol of maintenance for 3 years. It is known that patients do not tolerate the drug, but some do reach somewhere.
Sure, sir, sure. I think you have discussed about the dosage of the BCG. What is the dose being used? You have already presented the slide. And what is the BCG maintenance period in practice? Any difference?
The best protocol still mentioned with the world over bladder cancer consensus group is the maintenance of 3 years.
Sure, sir, sure. So thank you so much, sir. And thank you so much to our, of course, as Dr. Srivatsa has rightly mentioned, to Dr. Shreya and Dr. Rahul Pradhan for presenting the case. For the closing remarks, I would like to invite Dr. A.K. Ved.
Thank you, everyone. And it's been a great 1.5 hours of academic discussions. And as a medical oncologist, being in the company of so many accomplished professionals from uro-oncology has been a real experience. And I thank everyone for educating all of us. I'm sure the students, the young oncologists and oncologists in the making would have benefited from the deliberations.
Yes.
Everyone has been very patient, very academic, and so insightful. My special thanks to all the faculty and the young oncologists, Shrey, Rahul, for presenting their cases. And I'm sure it's going to be a great experience to both of you. And also thanks to all those who joined this evening for the proceedings. And of course, as I said in the beginning, thanks to AstraZeneca for their commitment. Ritika, you are there on the program, and Priyanshi, Rajesh, everyone, and my colleagues at the Indian Oncology Foundation for laying out this platform for the academic activities time and again. Thank you once again. Take care, and hope to see you soon enough for the number 4, which would be the muscle invasive bladder cancer. Take care. Good night. See you soon.
Yes, sir.
Thank
Thank
you.
you. Thank you
Thank
so
you
much
very
to the
much. Thank
faculty.
you.